Okay, kindly confirm that my screen is up.
Okay, your screen is up. I can see your screen.
All right, thank you. Would you want me to do video, or you are comfortable with audio?
We are okay. Anyone that works for you.
Yeah. Okay, let me show my face. Okay, good afternoon, all.
Good afternoon, sir.
Good afternoon. A special thank you to the organizers of this webinar. I want to say thank you to SynLab for their consistency in bringing up timely and insightful discussions that are geared towards strengthening our health systems. I'm very happy and privileged into innovative health financing that would improve the accessibility of the people, especially the vulnerable, to quality and affordable healthcare. Trying to move my slide, good. So, as way of introduction, enabling health financing for complete patient care involves the strategic collection, pooling, and spending of funds to ensure all individuals access comprehensive health services without financial hardship. Effective financing reorients the health system towards primary health care, ensuring that hospitals and clinics have the resources to provide high-quality integrated treatment. Now, taking a look at the core functions of health financing, we will agree that in order to achieve complete patient care, the health system must optimize the three interconnected functions of health financing. What are these three interconnected functions? Number one is revenue raising or revenue mobilization. This refers to mobilizing funds from diverse sources, including government budgets, which is usually general taxation, mandatory or voluntary insurance schemes, external aids, and private out-of-pocket payments. Number two, core function of health financing is the pooling of funds. This refers to accumulating prepaid funds to share financial risk across the population, which protects individuals from catastrophic medical costs, meaning the risk of ill health is shared among the population. The sick or the sickly share the risk with the healthy. The aged share the risk with the younger ones. The weaker ones share the risk with the older ones. The third core function of health financing is strategic purchasing. This refers to allocating the pooled resources to health providers through payment models that incentivize quality, efficiency, and care coordination. Now, let us take a deeper look into revenue raising and mobilization. Revenue raising and mobilization for health financing is the process of generating sufficient and sustainable funds to provide health services while ensuring financial protection for all citizens. To achieve universal health coverage, governments are increasingly shifting towards domestic resource mobilization to reduce reliance on declining external aid and regressive out-of-pocket payments. Now, the core revenue raising strategy deployed by the government usually include the general tax revenues. This is the most common public funding source that involves the direct income taxes, indirect taxes or the VAT, the value-added tax from sales. Also, we have the social health insurance, which is a form of compulsory prepaid contribution from employees and employers, which is usually often based on wages and salaries. We also have the health taxes, or what we call the sin taxes. These are excise taxes on harmful goods like tobacco, alcohol, and sweetened sugar beverages that simultaneously raise revenue and discourage unhealthy behavior. Then lastly, we have the earmarked levies. These are specific taxes that are dedicated to health, such as the percentage of petroleum company profits, mobile phone airtime, or tourism. So these are the traditional models, traditional ways through which government raise revenue for the health sector. According to the World Health Organization and the World Bank, sustainable progress in healthcare typically requires that public spending of at least 5% of government GDP, or 15% of total government expenditure, the one we usually call Abuja Declaration on healthcare. And World Bank recommends that out-of-pocket payments should be less than 20% of the total health expenditure, and also essential health service spending of roughly $86 to $90 per capita annually in low and middle income countries. In the face of dwindling world economy, donor fatigue, shifting global priorities, advancing technology, for us to make healthcare financing more accessible and inclusive, we will need to explore more innovative financing models beyond the ones that have been described, beyond these traditional models. Now, so let us look at innovative financing models, innovative resource mobilization and financing models that we can deploy into our health system. Innovative financing for health refers to mechanisms that move beyond traditional government budgets or donor grants to mobilize new resources or improve the existing resources. These models often involve public-private partnerships, market-shaping incentives, and outcome-based payments. Outcome-based payment, one usually referred to as results-based payments. Innovative health financing models aim to bridge the gap between traditional government budgets and the actual cost of providing universal health care by leveraging private capital, risk-sharing mechanisms, and outcome-based structures. These models move beyond just conventional grants to ensure long-term sustainability and efficiency. So let us take a look at some of these innovative models. One is the blended finance. The blended finance. Blended finance strategically combines public or philanthropic concessional capital with private commercial investment to reduce the risk associated with projects. Blended finance is a strategic approach that combines public funds or philanthropic funds with capital finance, private capital finance, to support projects that contribute to sustainable healthcare development. The primary goal is to de-risk projects, that is, to reduce the risk associated with projects so that private investors might otherwise find it profitable or they feel more confident and comfortable to invest into these projects. Many health projects come with a lot of risk, and many commercial banks, private investments, they find it difficult to invest in health projects because of this risk associated with health projects. So the essence of blended finance is to reduce the risks associated with health projects so that commercial investors can come in and invest. So the core concept of blended finance is what we refer to as risk-return balance. Risk-return balance. The underlying problem is that many critical development projects carry high risk, such as political instability or currency fluctuations, that deter commercial banks and private investors from investing into such projects. So what happens is that public or philanthropic donors provide the catalytic capital. This funding accepts higher risk or lower returns to create a cushion effect, making the overall project attractive enough for private investors to join. An example is the Global Fund blended finance in India and Indonesia that is used to incentivize health system reforms. The second one is the outcome-based financing or results-based financing, which we usually call pay for success. This is a more familiar model in many programs in Africa, including Nigeria. If you are aware with the swap that is going on with the Federal Ministry of Health, there are a lot of projects that follow this model, this result-based financing. Payments are made to health providers or local governments based on verified outputs, such as the number of children vaccinated. Funds are only disbursed after specific verified health targets are achieved. The third one is the social impact bonds or the development impact bonds. Here, private investors provide upfront capital for a health program. They are repaid with interest by government or by a donor only if the pre-agreed outcomes are met. So it's the reverse of the initial one. That is the private investors now go into the project with their funds after certain agreements have been made with the government or with the donor. So the private investors track the outcome of the health project So once the private investors are able to achieve the set agreement, what happens is that the government or the private or the donor reimburses the private investors with interest, with their profits, after those targets, those health targets have been met. So number 4 that I want to talk about are the market shaping mechanisms. The market shaping mechanisms. Market shaping mechanisms in health involve deliberate interventions to address market failures. Failures such as high prices, foreign exchange fluctuations, unpredictable demand, or lack of innovation, so as to ensure that life-saving products reach those in need. Now, market shaping mechanisms include the following. 1, pooled procurement. Pooled procurement aggregates demand from multiple buyers, usually from many countries, into a single large order to increase the bargaining power and achieve economies of scale. For example, Gavi uses pooled procurement to secure low prices for vaccines. By 2023, the price of pentavalent vaccine, pentavaccine is one of the key vaccines that our children take. It's part of the childhood vaccines. So by 2023, the price of pentavalent vaccine was reduced to 1/3 of its 2006 price through this innovative financing mechanism. The Global Fund also uses pooled procurement mechanism to lower the cost for antiretroviral drugs, contributing to about 50% price reduction. 2 is what we call volume guarantees. Here, donors or organizations guarantee a specific purchase volume to manufacturers, reducing their financial risk and incentivizing them to lower their prices, even to enter the market. This mechanism was used to expand the production of 3-HP. 3-HP is one of the drugs used for TB prevention in the TB program. So this mechanism was used for this 3-month course of TB preventive treatment through manufacturers, leading to a price reduction of up to 32% of this medication. The third one is what we call advanced market commitment. In advanced market commitment, here a donor commits to subsidizing the purchase of a product that is not yet fully developed or widely available, provided it meets certain specifications, meaning that a donor commits to a particular product that if you can develop this product, we will assure you that we will buy the product as long as it meets 1, 2, 3, 4 conditions. So advanced market commitment guarantees the purchase of vaccines or drugs at a set price once they are developed, incentivizing research and development of pharmaceutical industries, especially for diseases that are predominantly common in low-income countries. Example is the pneumococcal AMC, which likely increased the adoption of pneumonia vaccines in low-income countries, providing a predictable market for manufacturers. Number 4 is the ceiling price agreement. The ceiling price agreement. This involves manufacturers capping the maximum price of a product for specific regions or countries, often in exchange for guaranteed demand or regulatory support. So there will be an agreement. Manufacturers will place a cap, a ceiling to the price of this. Or okay, this product that is coming to Nigeria will not go beyond so naira, as long as the government or the donor will assure us that you will buy so volume of the product. An example, in 2017, a ceiling agreement was brokered for a new dolutegravir-based HIV regimen, ensuring it remained affordable for low-income countries. A similar example was the agreement to cap the price of HIV test kits at $1 per test to increase accessibility. 5 is what we call product subsidies. Here, financial support is provided to lower the end-user price of a product, making it competitive with older or less effective alternatives. An example is the Affordable Medicine Facility for Malaria, which was implemented in 2010 as a pilot program in 8 countries, including Nigeria. The intervention provided a buyer subsidy for ACT, artemisinin-based anti-malaria treatment drugs. This lowered the price of high-quality malaria treatments to gradually phase out less effective anti-malaria monotherapy. 6 is the antibiotic subscription models. Antibiotic subscription models. This model aims to lower or to discourage overprescription of antibiotics and reduce the emergence of AMR, antibiotic resistance. What happens here is that payments are made to manufacturers and the payments are not linked with the volumes of sales. This tends to incentivize innovation without encouraging overprescription. Pilots for this model are currently being implemented in the United Kingdom and Sweden to combat antimicrobial resistance. And the last market shaping mechanism I'll be mentioning is the strategic demand forecasting. An example is the development of market shaping roadmaps for vaccines like the Ebola vaccine and malaria vaccine by Gavi to provide long-term visibility to manufacturers and inform procurement strategies. The next innovative financing model we'll be talking about is the community-based digital and mobile solutions. Digital and mobile solutions are innovative ways of ensuring equitable, accessible, and inclusive health financing. Implementing biometric and mobile enrollment systems can rapidly scale insurance coverage, especially at the community levels. This has been demonstrated in African countries like Cote d'Ivoire, which led to health insurance reaching about 68% of the population of the people of Cote d'Ivoire. We have the blockchain and smart contracts that are used to automate insurance claims and reduce fraud through transparent and immutable ledgers. Medical crowdfunding platforms like the one in Kenya called M-Akiba use mobile technology to pull small savings from the public for health investment, reducing the risk of funds being diverted to other needs. While mobile money levies explore small taxes on mobile money transfer. Every transfer you made, maybe 10 kobo, 1 kobo, 1 naira is deducted for every bank transfer, or telecommunications to augment healthcare funds. We also have solidarity levies, where very small amount of money, mandatory fee, is paid on specific industries like airline tickets. Once you buy an airline ticket, a particular amount of money is deducted. This method was used by UNITAID to fund HIV/AIDS and malaria treatments. Micro contributions allow individuals to make small voluntary contributions during everyday transactions, for instance, while making travel bookings to support global health. We also have as a service and leasing models. This model reduces the massive upfront capital required to acquire expensive medical technology or equipment. Instead of purchasing expensive machines like the CT scan or the MRI scanning machine, facilities pay a usage-based fee that often covers maintenance and training. Also, we have the community-based insurance, which is quite similar to microinsurance or mutual health insurance. Communities at the grassroots contribute premiums to a local fund, often supported by government or donor organizations, to ensure that the poor are covered. Microhealth insurance is a low-cost health coverage model designed specifically for low-income individuals and families, often in the informal sector. It functions through risk pooling to protect members from the poverty trap caused by high out-of-pocket medical expenditure. The three main defining criteria for this model, for a model to be called community health insurance, community-based insurance, or micro-insurance, there are three main defining criteria. Number one, the target population must be that of low-income individuals or low-income households. Number two, participation must be voluntary. And number three, there must be provision of health insurance in exchange for services or in exchange for premiums paid by the enrollees. This model prevents families from selling their properties or their assets or borrowing money at high interest rates to pay for medical emergencies. Another innovative model is the philanthropic adoption model. Philanthropic adoption model. This model is currently popular in Imo State and it is christened ImoCare. It's an emerging strategy that high net individuals, rich individuals, of course in Nigeria, this includes politicians, they pay premiums for low-income citizens, and this fosters a culture of insurance while increasing the pool of covered lives. So instead of every time buying hairdressing machine, petrol generator, buying motorcycles or wheelbarrows for their constituents, what they do is that they pull this money together and pay for this philanthropic, using through this philanthropic adoption model to pay premiums for their constituents. Now, let us look at leveraging digital platforms for easier access and affordability. Digitalization automates revenue collection. It automates resource pooling and strategic purchasing. Mobile wallets and mobile payments allow users to save, send, and spend funds, especially for healthcare, reducing the risk of funds being diverted to other needs. Blockchain and AI ensures transparent and immutable records for pooled funds and reducing fraud and mismanagement. AI helps to optimize resource allocation by predicting patient demand, identifying priority areas of higher clinical needs. Super apps are integrated platforms that rebundle healthcare services into a single user-friendly interface to allow a reduced administrative cost. A super app is an all-in-one mobile app, web app application that integrates multiple seemingly unrelated services into a single digital ecosystem. Instead of the user having separate banking app for his banking, for his bank, for his insurance, pension, messaging, banking, shopping, a super app combines these into one interface with a single sign-on and an integrated payment system. Stakeholders' involvement and their roles. The success of any innovative model is highly dependent on the degree of stakeholder involvement. The government acts as the primary steward by formulating policies, providing tax-based subsidies, and earmarking health taxes or sin taxes, for example, on tobacco or on sugar, to fund public health initiatives. The private sector unlocks innovation, like what CLAB is doing presently, by providing specialized services, managing public-private partnerships for infrastructure, and also introducing cost control technologies. We must appreciate CLAB as an organization for leading in this regard. The development partners provide critical seed and capital, technical assistance, and blended finance to reduce the risk that private investments are scared of, especially in underserved regions. What are the critical challenges that we should expect when we try to explore innovative health financing models? Political will. Investments in secondary and tertiary care are often prioritized over the more cost-effective primary health care due to political pressure. Many of our politicians and political leaders are under pressure to build gigantic teaching hospitals, gigantic secondary health care, which most times are not cost-effective. They are not cost-effective, instead of investing more in the primary health care. Adequate funding is an issue. The constraints of fiscal space in our budget and declining external aid are other potential challenges. Digital innovation is on the increase in Nigeria. However, we are still far behind when it gets to the issue of reliable health data. Ensuring adequate coverage for vulnerable groups. Presence of large informal sector. We have large informal sector with little or no means of identification. Fragmentation of finance models. Infrastructural deficit and inefficiency and corruption. These are challenges we have to address as key stakeholders. Let me conclude by saying that innovative health financing is a critical catalyst for achieving the WHO goal of universal health coverage because it addresses the massive funding gaps that traditional aid and limited domestic budgets cannot bridge. By leveraging non-traditional sources, what happens is that additional resources are mobilized to ensure all people access quality health services without suffering financial hardship. Beyond just raising capital, innovative health financing improves the efficiency and equity of health systems by shifting the focus from simple resource mobilization to results-based outcomes, reducing reliance on unpredictable external aids and protecting vulnerable population from catastrophic out-of-pocket expenses. At this point, once again, I want to appreciate CLAB for coming up with this innovative idea, I think on a quarterly basis, and I want to appreciate the privilege for bringing me on board again this time. Thank you, and over from here.
Thank you so much, Dr. Adeniyi Adeniran. We actually appreciate you. We appreciate the wonderful presentation that you gave us. And there were so many wonderful things, so many key things that he said during the presentation. And I was so, for me, I gained a lot from the way he actually broke it down and in very relatable ways. I mean, his postulations about, or his prediction models for how we can actually have access to, health financing, especially in our part of the world here. Before I go on to the next speaker, I would like to state here that if you have any questions, kindly post them in the chat box. We are not going to have any voice questioning session. So if you have any questions, just put them in the chat box. And then I also want us to know that this webinar is being recorded and will be available on YouTube. So you can subscribe to our channel on YouTube. You can also follow us on all our social media platforms. We are on Instagram, on LinkedIn, Threads, and Facebook. So kindly follow us on our platforms. If you're actually in need of more, health information for yourself and for your family. Now we'll be moving on quickly to the second speaker, and I'll be introducing him. He has a very beautiful CV here, and so I'll be introducing Dr. Olumuyiwa Olusoya. Dr. Olumuyiwa Olusoya is a professional too. He's a healthcare management professional, and he has a very impressive CV. So Dr. Olumuyiwa Olusoya is a global thought leader, executive coach, healthcare finance information security specialist, a market entry and corporate strategy consultant, and an investor. He is the managing partner and CEO and founder of Insignia Health. With 2 decades of experience, Olumuyiwa sits on the board of companies and consults for governments, large corporate organizations, healthcare providers, and HNIs on healthcare finance, HMO, healthcare management strategy, and corporate strategy. Insignia Health provides precision consulting for health policy, business success, and excellence. Prior to this, he was the CEO of Health Partners HMO and Deseret International Hospital, and also held C-suite positions at IGI HMO, KBL, Healthcare, Oceanic Health, and Mediplan Healthcare Limited. Olumuyiwa is an alumnus of the prestigious IESE Business School, Barcelona, Spain's executive program, the Lagos Business Executive MBA program, College of Medicine, University of, he had his MBBS degree at the University of Ibadan College of Medicine, and is an honorary fellow of 2 prestigious healthcare finance institutes, Institute for Healthcare Finance and Management, and Institute for Health Insurance and Managed Care of Nigeria. He's a former member of the Executive Committee of Health and Managed Association of Nigeria and an Association of HMO Businesses in Nigeria. He's a certified member of International Systems Security Certification Consortium, the world's leading information security body, and has a global certificate in cybersecurity. He's also a member of International Society of Pharmacoeconomics and Outcomes Research, and is a member of the American Society for Quality, and a 6 Sigma Black Belt trained professional. That's interesting. So you are welcome, you're welcome today on the webinar. I'm sure we've all had, it's very, very impressive bio. So I'm sure he's not going to deliver. He's not going to deliver anyhow, and he's going to deliver something that I'm very sure we would all benefit from at the end of this session. So he's going to be speaking on financing beyond treatment. Financing beyond treatment, covering prevention, diagnostics, and continuity of care. So Dr. Olumuyiwa Olusoya, you're welcome, and you have 20 minutes, and you're welcome. We appreciate you for coming. You're welcome, sir.
Thank you very much, Dr. Woye. I hope everybody can hear me. Is the audio clear?
I can hear you.
You can't.
Yeah,
How about now? Is it better now?
No, I can hear you. I can.
I can hear you.
Oh, okay. Everybody can hear. Okay, that's fine. I just wanted to confirm that. Okay, thank you very much. I'm pleased to be here. It's an honor to be here to speak to that topic. Good afternoon, distinguished colleagues, all care leaders, partners with SynLab. I'm Dr. Olumuyiwa Olusoya. I'm the managing partner and CEO of Insignia Health. And it's my distinct privilege and pleasure to be here to speak to you on this month's or this quarter's SynLab webinar. The title of my presentation is deliberate, and from the organizers, it's very specific. It's financing beyond treatment. What are the things we need to look at? And I choose my words carefully for every slide of this presentation, because I want you to capture the most important shift in our healthcare system, and that shift that we need to make at this point in time. For a long time, healthcare financing in Nigeria and indeed Africa has been synonymous with paying for treatment after people have fallen sick. So today I want us to reimagine the possibility where, we can finance the full spectrum of care from prevention to treatment. And over the next 20 minutes, I'll take you through the evidence, I'll take you through the economics and the practical solutions covering prevention, diagnostics, and continuity of care within our financing frameworks. Thank you very much. The next slide, please. So we're looking at different areas, looking at the current state of financing in Nigeria, shifting from treatment to the full spectrum of care and embedding prevention and diagnostics in Nigeria. So this slide is not showing properly in a full stream. Do you want me to display it from here? It's not showing in presentation mode. Okay, I'll just continue while we wait for that. Okay, so
I think because it was shared in PDF, so that's the reason why I'm trying to figure out. It is shared in PDF. It wasn't like in PowerPoint. So I'm trying to figure out how to make it. It was in
give me
PDF,
access
it's in
then.
PDF format.
Please give me access so that
I mean,
I
you
can
have
share.
access to share, please. You do have access to share.
Okay, thank you very much. Let me do that. Thanks so much. Okay. Okay, so we'll do that right now. Okay. So yeah, I think we're back now. Everybody can see that now. Okay, so we'll be looking at the current state of financing in Nigeria, the global Nigerian landscape, out-of-pocket burden, and the case for change. What needs to change at this point in time? Then how we need to shift from treatment to full spectrum care for everybody. We need to reframe our financing models and discuss how we need to be proactive about our models going forward. Then how do we embed prevention and diagnostics in our healthcare financing? That's very, very important. And this will be looking at integrating preventive healthcare checks and diagnostic testing into financing, healthcare financing packages or health plans, whether it's private health plans or social health plans from health insurance. Then what are the economics of early detection? What are the long-term costs that we are actually carrying right now that we can actually prevent through savings if we actually embed prevention and make sure that we do a lot of early detection and consistent follow-up. Then how do we enable continuity of care, financing post-treatment monitoring, chronic disease management, and other care pathways? And my own solutions, what am I putting forward as the solutions as we move ahead? So we need to realize that the global health financing challenge is huge. WHO says that 65% of all clinical decisions are based on diagnostics. That means to actually practice evidence-based treatment, a lot of work has to go into diagnostics, into confirming what treatment the person should have or the treatment the patient to have. And it's been confirmed about $300 billion. It's represent the size of the global preventive healthcare market as of 2024. And 90% of all US healthcare spent are on chronic diseases. I'm using the US healthcare market because I know that they spend a lot on healthcare and want to use that to compare, not to say that Nigeria will be able to achieve that, but to use that as a benchmark and now see what we can do within our resources. The global preventive healthcare market is projected to reach about $922 billion by 2030 and is growing every year by about 12%. And chronic diseases continue to represent a major part of healthcare spent everywhere in the world. That's very, very important. Now, bringing it home to Nigeria, it is confirmed that nothing less than 70%, in fact, above 70% of of spending in healthcare is done out of pocket, where less than 25% is from, financed by public funds. And currently in Nigeria, we have less than 10% of Nigerians under any form of health insurance, whether social or private health insurance at the moment. So that's what we have for the country. So as at the end of 2025, the National Health Insurance Authority confirmed that only 21 million Nigerians have any form of health insurance, whether social or private health insurance. And this represents about 10%, less than 10% of the population. If we're using about 230 to 235 million for 2025. And for our 2026 budget, 4.3% was allocated to healthcare as a whole. I'm not talking about healthcare financing here. I'm just talking about healthcare as a whole, 4.3%. So by the time you break it down to how much is actually now allocated to healthcare financing, you find out that it's actually a very small percentage of that 4.3% at the end of the day. In Nigeria, we have doctor-to-patient ratio of 4 to 10,000, whereas the WHO recommends at least 1 to 600 for our population. So we have a lot of challenges. There's no doubt about that. Every year, about 12 million Nigerians are pushed into poverty from very catastrophic healthcare expenditure that they have to bear out of pocket, and this is not acceptable. The 2022 Healthcare NHIA Act seeks to drive mandatory healthcare insurance in Nigeria through enforcement. But currently, the enforcement is very, very weak, and we'll be talking about that and what we can do about that. And one of the major challenges we also have in Nigeria is fragmented financing of our healthcare system. There is no uniformity from the federal to state to local government level. The healthcare pools, funds are fragmented across those 3 levels. And that is where we are not getting a lot of efficiency in the system. Social schemes don't talk to themselves. Private schemes don't talk to themselves. Everybody is creating healthcare financing pools in silo and is not helping the system at all. And that's one of the major challenges also. And most of the benefit packages, whether for the social schemes or for the private schemes, are heavily treatment focused, neglecting the prevention of care. So what are the opportunities? For Nigeria, we seek to move from 21 million people that are covered to 230 million and catch up with the population. There are a lot of regulation right now on mandatory health insurance. Lagos State, for example, is driving mandatory health insurance with their social health insurance scheme called Ilera-Eco, and a lot of other states are also following to do the same. We have over 83 HMOs accredited by the NHIA to drive health insurance as health insurers. And we have a lot of improvement on digital health across the country, enabling new financial models that we can look at. So what we need to do is to shift from treatment to full spectrum care. We need to look at our current models, which are usually triggered by illness. There are benefits that cover consultation and prescriptions. The diagnosis are seen as a cost, not as an investment. There's no incentive for preventive health checks, and there is episodic care, and there's no continuity of the framework of treatment of care. And there's a lot of high claims because of this late stage presentation. So we need to move to financing, making sure that healthcare financing models actually start before the illness, so that we start at the prevention level. We need to ensure that the benefits include wellness packages, screenings, diagnostics. This is where CINLAB comes in. This should be integrated into the framework for the healthcare financing and the plans. And we should create incentive for people to do annual health checks and screenings, and make sure we have structured pathways for continuity as we move across this platform. So this is what I'm talking about. This is the full spectrum of care that we should be advocating. We find out that from the genetic predisposition to primary prevention to secondary prevention to treatment intervention itself and to continuity of care, that is the spectrum. We need to ensure that our financial models actually cover all the spectrum. so that if you have the costing go into the actual analysis for the plans, whether they're social plans or they're private health plans, you can actually pick up all these things along the way and help to prevent those catastrophic claims that will come up down the line. So how do we embed prevention and diagnostic into healthcare financing? One of the ways we can do that is to ensure that mandatory healthcare screenings and packages built into the plans, depending on the budgets and the financing of those plans. Annual screenings, gender-specific screenings to target particular illnesses that require different ages for different gender, metabolic panels, liquid profile, and things like that. We can look at diagnostic integration models where HMOs or health insurers or social schemes can bundle diagnostic areas on their benefit packages and actually get it pre-authorized so that it is not abused. We can also look at capitated payment models for diagnostic partnership and coverage, where insurers or social schemes can ring fence between 15 to 20% of their premiums to take care of the prevention through diagnostics. Then we can do risk stratified screening, which can be also used to target high-risk populations, people that are genetically predisposed, or we can use lower premiums for high screening compliance, where we can actually encourage people that they will get incentives or lower premiums if they actually imbibe the annual medical screenings that we have prescribed for them to address the risk. Then using technology, telemedicine, remote patient monitoring, wearing wearables that can track data and actually pinpoint challenges, emergencies ahead of time, where people can get help through the use of Insure Health tech platforms and all that. So this is one of the best slides of this presentation. If you look at this slide, you see the economics of early detection using some common conditions like breast cancer, diabetes, hypertension, cervical cancer. And you see how the costs actually skyrocket to catastrophic claims level when there is no early detection. You can see for breast cancer, it goes as high as times 8.5, for diabetes times 6, hypertension times 5, and cervical cancer almost times 10, times 7.5. So we need to be able to track these things early to actually prevent catastrophic claims along the way. So how do we enable continuity of care? I want to make sure that we do post-treatment monitoring, schedule follow-ups, diagnostic surveillance, and compliance tracking. We want to make sure that for most of the NCDs, non-communicable diseases like hypertension, diabetes, asthma, and the likes, glaucoma, and all that, we want to make sure that we do a lot of medication adherence and remote patient monitoring through technology, use of phones, use of apps, use of wearables, and rehabilitation and recovery through physical therapy, mental support, and also a lot of return to work programs. Then wellness maintenance, the annual screening programs, lifestyle coaching and modifications, and prevention optimization. So the way we can actually finance this is by looking at bundled care payments, where single payments can cover entire care episodes, capitated diagnostic partnerships, or fee-for-service, the way it may be, if that will be more affordable, but I don't think fee-for-service is always affordable. Capitated arrangements are always better. These are models that we need to explore in Nigeria. Then the third financing mechanism, which I'm proposing, which is also standardized, is outcome-based financing, paying for performance, paying for results, and all that, where premium discounts or rebates are given to enrollees who complete full care pathways and also do a lot of follow-up screenings. So this can be used to actually intensify people towards the right behavior. So from learning from a few countries, we have Rwanda, we have United Kingdom, and we have Singapore. We can see how they've used some of these principles to actually make sure that they have a full spectrum healthcare financing. For Rwanda, they have their community-based health insurance program covering about 91% of the population, with the focus on prevention, and there's a lot of integration of diagnostics at the community level. And the result is that they were able to reduce out-of-pocket spending by up to about 90% in Rwanda. In the United Kingdom, free wellness checks for age 40 to 74 every 5 years, and for people with certain chronic diseases, for example, embedding their cardiovascular risk screening. I know they have very strong programs for diabetics, people with kidney disease, asthma, and all that. And they're able to reduce a lot of these things, especially for cardiovascular diseases, by also about 20% yearly. Then another good example is that of Singapore, through their MediSave and MediShield. They're able to use tax advantage health savings and also subsidized cancer care and non-communicable diseases. At the end of the day, they have one of the highest life expectancy in the world today. So how do we apply this to Nigeria? For Nigeria, we can actually borrow from Rwanda's community models or look at what will fit us, borrowing from all these 3 or more models, and come out with a model that best address our current situation. Solutions for Nigeria, for the government and the NHIA, the National Health Insurance Authority, I would say that it's good to mandate preventive health benefits for every NHIA level, NHIA benefit package. And looking at what they've done up to recently, they've done that. They have some preventive screenings in the plan. So we need to review it again and look at what works at the moment and adjust it. Also, allocating BHCPF funds for diagnostic screening. This is also very important. And also to enforce mandatory health insurance across. But if we're able to do this, we're able to achieve universal baseline for prevention. We're able to reduce at least 30% of emergency presentation. We're able to expand coverage to above 50 million Nigerians before 2030. For insurance and HMOs, the idea is to redesign benefit packages to include wellness bundles. But before you can do that, the pricing of the insurance packages must be properly done, even for social schemes. We have situations whereby the social schemes, even their premiums are not actually sound to carry the burden of the claims that they are supposed to carry. So we found out that they are not able to address these challenges because they've not actually priced right. For diagnostic providers like SynLab, it's good to develop affordable screening bundles in partnership with health schemes, whether social health schemes or private health insurance like HMOs, to encourage and expand point-of-care testing and community laboratory access for a lot of communities and digital integration. For employers, they need to adopt comprehensive employee wellness programs, annual diagnosis screening for their workforce, and be willing to pay the right price for healthcare financing for health insurance schemes. Pricing has to be right for the schemes to be efficient and to be able to cover this full spectrum. If we're able to do this, we'll be able to reduce absenteeism in the employee workforce, higher workforce productivity, and lower, at the end of the day, insurance premiums across board as more people come into the spectrum, come into the pool rather. I propose a 3-layer or a 3-phase system for implementing this. We can look at addressing the prevention models, making sure that those schemes and plans, whether on the social schemes or on the private schemes, have prevention integrated into them. Then set up diagnostic provider and health insurer or health scheme partnerships, financing partnership, whether capitation or fee-for-service, but I'll propose capitation because it helps to manage costs better. Then digital health platform development. We have the connected health system principle that's coming up. We also have the widespread national digital health platform that we can actually use to deliver this. And the NHIA can actually drive preventive health benefits through their own advocacy also. Then second phase is to expand this to all states. and to encourage employers to actually embrace prevention as part of their plans, and also devote part of the BHCF fund for prevention. Then national prevention basic standard that will have prevention built into every social plan and also every private healthcare plan. Universal screening, compliance incentives, and an integrated healthcare system that helps to drive full spectrum financing. These are the things that we need to do to achieve this over the next 5 to 10 years. So moving forward, I would say that healthcare financing must evolve from a treatment-only model to covering a full continuum of care. And also, prevention and diagnostics are not costs. They are investments that have proven that they give over 5x or more in returns if they are implemented properly into the design of the plan, into the financing of the plan. HMOs and health insurance schemes that have embedded preventive diagnostic packages will continue to gain competitive advantage and lower their plans over time. But to balance this statement, I would like to say that HMOs cannot do it alone. There must be standardization of benefits. There must be standardization of pricing across social health schemes and private health schemes for HMOs to be able to achieve this. Then diagnostic providers like SynLab are critical partners, in preventive care financing ecosystem. So I want to encourage SynLab to do more and other diagnostic providers to make sure that advocacy is going on to build in all these preventive principles into the design of plans so that the costing, the provisioning has been made for the costing into the health insurance premium. Nigeria's NHIA Act has provided a regulatory framework, but now we need to build on it to make sure that it works. Therefore, there must be a multi-stakeholder collaboration between government, between social schemes, between private schemes, between private health insurance, HMOs, diagnostics, and other healthcare providers and employers to make this work. So in closing, I'd like to say that the greatest wealth is health. And financing prevention is not just a policy choice, but it is the most intelligent economic investment that a nation can make. Thank you very much for your time.
Thank you so much, Dr. Olumuyiwa Olusoya. It's been such an insightful one, and there are some words on marble there for me. And one of those words is healthcare financing model should start before the illness. And of course, the fact that you stated that genetic predisposition to a continuity of care, is what characterizes a full spectrum of financial model. I think this is, for me, that's those are very key words on marble. And then the final word you said is that the greatest wealth is health. And thanks so much for that insightful presentation. So if you have questions, please put your questions down in the question and answer chat box. There's not going to be any voice questions, so you put them down. And I'm sure our lecturers are more than capable to handle your questions. And of course, this webinar is going to be available on YouTube, so it's been recorded. So you can always follow us on YouTube to be able to rewatch, it again, because there's so many things there that you may not be able to internalize within the time frame that we have stipulated for it. So you can always go on YouTube and then watch it again as many times as you would like to. Of course, also follow us on all our various social media platforms on Facebook, Instagram, Threads, and LinkedIn. So without wasting much of our time, I'll move on to the next speaker. She has a very, very impressive CV here, and I don't want to talk so much. Let me just introduce to you Ms. Jenny Nwokwe. She, very interesting. She is a systems engineer turned a visionary entrepreneur, and she's had over 8 years of experience planning big techs, managing consulting, and the US federal government. She holds a BS in biomedical sciences with a minor in anthropology from the University of South Florida, and an MS in Forensic Science from Stevenson University, and an MS in Systems Engineering from Georgetown University. In 2000, Jenny relocated to Nigeria with her family and experienced firsthand the challenges of accessing reliable, affordable healthcare, especially for those with chronic conditions. This early experience planted the seed for Clafia, a healthcare fintech platform she founded to build the financial infrastructure for health in Africa. Clafia provides health savings accounts that enable individuals, employers, and diaspora to save, earn interest, and pay for care across a growing network of over 3,000 vetted providers. Users can access services ranging from consultations and diagnostics to wellness and mental health support via web or USSD without breaking a bank account. Clafia integrates with financial institutions, employers, and remittance platforms to make healthcare more affordable, accessible, and tailored to the realities of emerging markets. Outside of our work with Clafia, Jenny remains a dedicated mentor, an advocate for youth-led innovation and inclusive entrepreneurship. She has supported aspiring founders through capacity building programs, pitch competitions, and strategic fundraising guidance, particularly those from underrepresented backgrounds. Ms. Jenny is going to be speaking on how providers, insurance, and patients can drive sustainable health financing. So you're welcome, Ma. I'm sure it's going to be a very, very interesting, discourse, just like the other lecturers have done. So you're welcome. You have the floor, Ma.
All right. Can anyone hear me?
Yes,
Hello?
we can. We can hear you.
Okay. Thank you so much. All right, I'd like to share my screen. Okay. Just making sure it's side by side. All right. Can everyone see my screen? Is that yes?
Yes, yes.
Okay, awesome. All right. So thank you so much for the opportunity to be here today. I've learned quite a big deal from the other speakers who talked about like healthcare financing from, either from like a policy or government side of view, or from, a diagnostic side of view as well. And I thought it would be most helpful to just present a use case of what Clafia is currently doing in the market to help finance consumers, everyday Nigerians, good health and well-being. So the title of my presentation is called The Financial Infrastructure Powering Personalized Health and Wellness in Emerging Markets, Nigeria being an emerging market. God, sorry. Nigeria being an emerging market. And I will just start with my slides. So in 2021, we started Clafia in Nigeria with the mission to bring healthcare closer to people. And that is still our challenge. That's still our mission today. However, when we got into the market, we encountered two major problems. The first one being poor healthcare financing infrastructure. In a typical country or market, health insurance tends to be like that financial infrastructure that pulls funds together from various resources so that it can help reduce the high out-of-pocket spend. I've spent most of my life living in the United States. I'm currently living in Nigeria now. But in the United States, I would say over 90% of Americans have some sort of health insurance, either through the employer or through the government. And if an American paid for healthcare out of pocket, they would be going into poverty because healthcare is very, very expensive. Now bring that to Nigeria and many African countries, many Africans in African countries, or even in emerging markets who pay for healthcare out of pocket. This very challenge prevents the ability to access good health and well-being. Couple that with the fragmented healthcare system. So I like to think of Nigeria. I say Nigeria has over 200 million people. So I like to think of Nigeria having over 200 million healthcare systems because everyone has their own unique way on how they access and engage with the healthcare system, right? They either speak to doctors from home, or they go to a hospital, or they go to their nearby pharmacy. There is literally no standardization on how to access healthcare in Nigeria. And so what that means is that people have an uneven way of how they access healthcare, and it just leads to a poor experience. And that is what we encountered in the market in Nigeria. Just to bring it into context, we started with using community health workers because they are an underutilized resources to bring healthcare to primary healthcare rather to Nigerians, especially in semi-urban and rural areas. And although our customers really liked the services that we provided, they kind of forced us to evolve. So we had to aggregate partners such as pharmacies, diagnostic partners, hospitals, mental health, so that when our customers and our patients needed continuum of care, they knew exactly where to go because we were going to refer them. And like I mentioned, the other thing was cost. So we had a few choices to make. We could either have been a health insurance company or pivot to a health insurance company, where like we would do what I think one of the speakers said that there were about 30 to 50 health insurance companies in Nigeria. So we didn't really know what we would be doing as the next health insurance company, being that they've somehow been able to capture only 10% of the market. Or we just do something new. So we decided to build the financial infrastructure for health and wellness in emerging markets, which is Clafia. And what exactly is Clafia? Clafia is a digital health and fintech platform that allows our customers to access affordable healthcare all on one platform. We do this in two ways. One, they get a health savings account where they can save, earn interest, so about 10% per annum, and use that money to pay for healthcare on our platform. And the second way is our aggregated healthcare platform, where we've aggregated 3,000 health and wellness partners, SynLab being one of them, where customers can book consultations on our platform, order lab tests, order medications, or they can walk into the nearest SynLab and use their HSA to pay and get 10% off. What does our infrastructure do? So for consumers, it helps to personalize healthcare spending and cut out-of-pocket spending up to 40%. For employers, they're able to set a flexible budget for employees and saving them 60% on their healthcare benefits. So instead of having a health insurance plan that their employees may or may not use, they get to open an HSA or health savings account for their employees, allocate a budget for them, and these employees can use that money to buy health insurance on our platform, and then also for things that their health insurance plan does not cover, especially for a growing young populace that are more so interested in the wellness side of things, such as going to the gym, such as eating healthy foods, or more skincare, or spa treatments. And then providers who are on our platform, they can expand their customer reach and boost revenue by distributing their services and products through our platform. There are four different pillars to our healthcare finance infrastructure for emerging markets on our. So I mentioned we have our health savings account. This health savings account allows us to distribute through the financial services system. So I believe like the previous speaker touched on this, where like, or I think it's the first speaker actually touched on companies building a super app. So instead of having a separate account, a separate app for like your banking or like your health insurance or whatever the case might be, because we have a financial product, which is our HSA, we can embed our HSAs with our partner banks, and their customers can use that money or use their HSAs to access healthcare on our platform. Second is our digital health clinic. It's like, I like to consider it as like a digital hospital. Does everything except like, having to do surgeries and the like. But through our digital healthcare clinic, you can get a concierge service where that is tailored to your needs. And it's both virtual and hybrid, or it's a hybrid experience where like you can request to speak to doctors, or you can have doctors or nurses visit you at your home. If you want your medications delivered to you, you can do that. Or if you want to go to the nearest pharmacy as well, our healthcare platform will help you find the nearest pharmacy closest to you. We have a digital marketplace where we've aggregated 3,000 health and wellness partners, where our customers can walk into any of our partners in our platform and use their HSA. It works just like as if you're using your banking app to pay for medications or pay for lab tests. But in this case, you're using your HSA to pay for lab tests or for like medications or whatever you want to access on our platform. And for the most part, you can get discounts. And then we are using AI. So AI is very, very like popular today. We've heard so many use cases of how AI is like influencing health or other industries, but particularly for Clafia, we have an AI-powered chat service called Chi-Chi. It's not just a health on AI symptom checker where you enter like some of your complaints and then it will provide some insights. It also elevates the experience on Clafia where it can also book these appointments for you, give you reminders. It can like order lab tests for you on your behalf. It can find the nearest pharmacy closest to you where you can use your HSA to pay for the services. And it also like uses the data that we have aggregated on you over the time and usage of you on our platform to help provide more insights on how you spend and how you access healthcare on our platform. So ultimately, it starts to learn more about you, and then it can give you suggestions or curated options of how to access healthcare. So why is now the time to access or to start working on the financial infrastructure for health and wellness in emerging markets? Well, we've talked about it. We have, I would say at this point, over-believed the point of like there's a gap in healthcare financing. Across the world, there are about 90% of people in emerging markets that lack adequate health financing, resulting into high out-of-pocket spend. There's rising healthcare costs. So healthcare costs in emerging markets are rising by 8 to 15% annually. There is a growing middle class that is going to demand better healthcare, especially since this middle class, this middle class, there's getting all kinds of work, either freelancing, and the world is becoming more global. And so naturally, they're going to want to have good and better healthcare, driving the demand for healthcare. So great opportunity. And there is reform in developed markets. So right now, there is a push for driving health insurance in emerging markets, particularly in Nigeria. But I would like to have us think about like the current health insurance plans that we see in the market today. Is it really conducive for our market? Does it meet all the needs of the unique challenges that Nigerians have or Africans have when they want to access healthcare? I believe that, health insurance, the way it is structured right now is changing, and we're seeing that in developed markets. And knowing that that is being changed in developed markets, being that there is a gap in our market with health insurance and the current health insurance plans that exist in the market today, could we like reimagine what these health insurance plans look like or health financing looks like so it can meet the unique challenges of Nigerians and people in emerging markets today? Go to my next slide. Okay, so this slide basically is like a use case, basically covers a use case on what we're currently doing with SynLab today. So I'm just going to play this video In this video, you see me, I'm being an influencer, and I talk about my experience of our partnership with SynLab, where our customers can use the funds in their HSA and get 10% off their any lab test that they want to book either on the SynLab's website or directly in the lab. So I'm just going to play this as very short. I'm going to need to get some lab tests done today. So before I got my test done, I booked a virtual consultation on Clavia's app where I got to speak to my doctor right away. She recommended some tests that I can take just to make sure that, I'm good internally. And afterwards, I went to my nearest SynLab laboratory location where I was greeted warmly. I told them the test I wanted to do, and I got to pay through my Clavia HSA. I got 10% off because, like healthcare these days are very expensive. So I'm really grateful for that 10%. Afterwards, I went to go get my test done. I'm really not a needles person, but it was pretty painless. And so it happened very quick. So I got to talking with the phlebotomist. We had a very interesting conversation. Overall, the experience was really, really great, and I'm happy I got to do my test today.
Many people delay testing because the costs are high and they're afraid of what they might find. But the truth is, the earlier you test, the more empowered you are to plan your future. With SynLab's partnership with Clavia, we're making diagnostics from fertility testing to full body checks more affordable and accessible to all. So today, you can get a 10% off when you pay with your Clavia Health Savings account.
So as soon as I got home, I was really surprised that I got my results in my email. Overall, I'm really excited about the experience. It's very convenient. I made my payment through my HSA. I got 10% off, and I was seen very quickly. I got my test done. So I'm just really excited about this experience, and I can't wait for everyone to experience what I just did today. Tell someone to tell someone, tell a friend to tell a friend. All right. So that basically is a video on Instagram that highlighted our partnership with SynLab that launched last year, where our customers, as you saw in the video, our customers can walk into any SynLab branch and use their HSA to pay and get 10% off. Another thing that we're doing with SynLab is that we want to also encourage saving. So I saw there was a question in the chat where someone was asking, how can we make healthcare affordable? Or I would say in this case, diagnostics more affordable, knowing how expensive it is in the market. I think that was just the gist of the question, right? So what we are currently doing right now in partnership with SynLab is launching our pouches, or a pouch, where you can save specifically for specific tests. So you see on the flyer here, you say for your health tests, your men's tests, your sexual health tests, or general tests. And when you contribute to your savings as well, and it just stays off of, you get 10% in, and when you're ready to do that test, you can take the money out and pay directly at SynLab and get 10% off. What this does, it not only just encourages, affordable, or provides a way for you to get access to healthcare in a more affordable way, but also helps to encourage more proactive healthcare seeking behaviors, because in this case, you're planning to get your test, right? And so you can leverage this, you can leverage your pouch to save just a little by little. And then when it's time for you to get your test done, you can use that money to do your test and also get 10% off. So why is my slides not going? All right. So that essentially just brings me to the end of my presentation today. I thought like this would be like a good way to basically show what it currently exists in the Nigerian market to help with healthcare financing, and also to help integrate and aggregate the healthcare partners that we have in our market so that it can be a seamless experience, making healthcare affordable and convenient regardless of your background. And that is basically the future that all Nigerians, all people in emerging markets, and just anyone around the world deserves. So that brings me to the end of my presentation. Thank you so much for giving me the opportunity to talk about what we've been doing at Clavia. Thank you so much.
Thank you so much, Jenny. We actually appreciate you for coming around, and you do a lot of amazing things with Clavia, and we hope you continue to do more. And of course, to all our participants, you should actually check it out. Actually makes your access to healthcare seamless, actually. So you should check it out. Now, before we take our question and answer, there's going to be a webinar poll, that will be displayed. Please kindly complete it before the end of this session. We'd like to hear feedback from you. So please kindly complete the poll before we end this session. Now to our question and answer sessions. I only have one question in the chat box, and then this question was directed at Dr. Adeniyi. Mr. Fengbadigun here is asking that, how can an average income earner access a comprehensive medical diagnostic services with some of the high-profile laboratory, considering the rates of their tests? So in essence, this person is just trying to say, Dr. Adeniyi, are you still with us? Dr. Adeniyi, are you with us?
Yes, I'm here.
Okay, so this question is for you, sir. Mr. Badigun here is asking that, how can an average income earner have access to a comprehensive medical diagnostic service, especially with some of the high-profile laboratories, and then high-profile laboratory, considering the rate of the test that they have for these tests? What are your suggestions for this? How do you actually think we can tackle?
Okay, sir. Thank you very much. I understand the concern of the participant who asked the question. But firstly, I want you to understand that health care is a social infrastructure such that it is based on need. Number one, you mentioned high-profile laboratories. Number two, you mentioned comprehensive medical tests. The question we'll ask is, one, do you really need comprehensive medical tests? Most of these tests are done based on need, based on your clinical history. So what we usually have is that I have such an experience about 2 or 3 days ago when a woman just came and brought about 60 pages of investigations conducted. 75-year-old man, even she did genotype, a lot of tests that probably were not necessary. What I'm saying now is that the participant should first ask himself, do you really need comprehensive tests? Because you express yourself as a middle or average income earner. So do you really need comprehensive tests, number one? Two, do you really need to decide to choose high profile, so to speak, laboratories? So those are the first thing you have to understand, that medical health insurance is not based on what you feel like doing, not based on the service you just feel like conducting, is based on need. So the idea is to use the funds from the healthy ones to take care of the sick, to use the funds from the rich to take care of the poor. So what I will first say is that, do you really need those investigations? And if you do, then you have to work with your HMO based on your organization and the other private HMOs that you can freely enroll with outside your organization. So it is based on the plan of your HMO, your insurance provider, your HMO, your health management organization, and also based on what your organization provides. By and large, health insurance is not based on what you feel like doing, the investigation you feel like conducting, the kind of treatment you feel like having, or the kind of hospitals you feel like accessing. Is based on need of individual. That's universal health coverage, based on what you need at the time you need it, without having to incur high catastrophic medical expenditure. Thank you.
Thank you so much, sir. And another question here. Okay. All right. There's another question here from one of our participants, who is asking. It says the average Nigerian does not value preventive care. Most people utilize health facilities only when they are critically ill Among other things, financial challenges is a determinant. Now, the question is this: how do we improve the health-seeking behavior of the community, especially vis-a-vis preventative care? Anyone can answer this. How do we improve the health-seeking behavior of the community, especially vis-a-vis preventive care? Dr. Adeniyi, Dr. Olumuyiwa, anyone can answer.
I think I can speak to that. Can you hear me?
Yes.
So I think well, the person has spoken the mind of most Nigerians. Most people believe that healthcare conditions and situations should not happen to them. We are very religious people, attend a lot of churches and mosques and all that. So that's general mentality. But the way to create that incentive, I spoke about it in my presentation, is to create incentives for people to actually embrace healthcare financing. But if we want them to embrace healthcare financing, we also have to integrate prevention in the healthcare financing, such that the healthcare packages have already been provisioned to have preventive screenings along the spectrum, so that we can actually save a lot of costs and encourage people to actually get good healthcare, where conditions will be detected early. We'll save a lot of money, we'll save a lot of complications, and the enrollee and the patient will be better for it at the end of the day. Having said this, ultimately, you cannot wait for everybody to decide whether they're going to buy health insurance or partake in healthcare financing or not. And that's why healthcare financing, healthcare insurance has to be mandatory. If you leave people the option of deciding whether they're going to do it or not, they're not going to do it. They're going to hold on to their faith and claim that I will not be sick in Jesus' name, or in Allah's name, I will not be sick. So no government waits for that. That's why there must be mandatory health insurance drive to bring everybody under the net, just like the way government is bringing everybody under the tax net right now, so that they can get a lot of funding. So we have to bring everybody under the health insurance net. You don't wait for them to make that choice. But when we're not doing that, we need to go back to our plans. Let's integrate prevention into the design of the social plans by the social schemes and the one by the private schemes. Thank you very much.
All right. Thank you very much, sir. I think it's now going 1 or 2 minutes left for the question and answer. I have a question here. If we had to prioritize on immediate change in health financing that could significantly improve patients' access, what should it be and why? Let me go over the question again. If we had to prioritize on immediate change in health financing that could significantly improve patient access, what should it be and why? We can hear you, sir.
For me, if I can do one thing right now that can change the way people access healthcare financing in Nigeria, the first thing I'll do is to make it mandatory. Although one thing will not solve it. So I'll reduce it to 3 things. To make it mandatory, that's the social health insurance scheme, to make it mandatory. Secondly, to ensure that there is uniformity from the NHIA federal plan to each of the state plans, where those plans are uniform. There is a standard benefits and there's a standard pricing. Because most people can afford social health insurance, not everybody can afford private health insurance. So the starting point should be the social health insurance scheme. Now, the third thing I would do, because one thing cannot just solve it, from bringing everybody under the health insurance net, making all the plans standardized, one plan. If you go to the UK, you cannot find 2 social health insurance plans there. There's just one NHIS plan. So if you bring them under that plan, they can call it any name. Lagos can call his own Ilera Eco, Ogun State can call it anything, but it's the same benefit package, is the same premium. Then the last thing that needs to be done to give everybody access is to make that the payment for the health insurance scheme, to make it portable, to make it affordable. And the best way to do that is to make sure that people can pay small every day. Let me give you a very, very basic example. The National Health Insurance Plan run by the NHIA is currently set as 38,000 per life. 38,000 per life. If somebody has to pay that daily, will be at the cost of, let me do the math here, 104 naira per day. That's at level 104. But if you ask an average Nigerian to cough out 38,000 per life to buy a social plan in a year, they will find it difficult to cough out that money. But if we can set up automatic debits on the cards that would take 104 naira per day to actually pay for that health insurance, you can find out that almost every Nigerian can pay for that. And the people that are so poor, they are indigent, they cannot pay for that. The other financing models that can be used to subsidize can now use to offset the cost of their premiums. But an average Nigerian, if we break it down to daily, they can actually pay, because most of them actually earn money daily, and they can make that payment daily seamlessly without even knowing that they are making those payments. So if I were to do things, that the things I do to create that immediate change and to give people access to healthcare financing. Thank you very much.
All right. Thank you, sir. So before I allow Dr. Adeniran to speak, the poll is already being displayed. Please kindly complete the poll, the webinar poll. We have 8 questions, and then they are not very difficult. Please, all our participants, help us to complete this poll. Please, it's on display right now. Please kindly help us to complete the poll. Thank you very much. Dr. Adeniran, you have the floor, sir.
Okay, a quick one, just yes, a quick one just to add to what the list that Dr. Olusonya has made. Another one important thing we need to do, if we must do one thing about the health insurance, is to aggressively address the large informal sector. We have a large informal sector that we really need to address, provide a unified means of identification and a comprehensive database of the informal sector. I mean, the roadside mechanics, the petty traders, the bike riders. There must be a unified means of identification. If it is to go by their NIN, if it's to go by BVN, whatever, there must be a means of identification so that we have a comprehensive database to capture this large informal sector. Just a little addition to what Dr. Olusonya has mentioned.
Thank you so much, sir. Please, again, the poll is currently being displayed. So please kindly complete the poll because we're getting to the end of the webinar. We've already overshot our time by a couple of minutes. So please help us to complete the poll, the webinar poll. So while you're doing that, this webinar has been recorded, and then it will be available on YouTube. So you can go back to our YouTube channel and follow us there, subscribe to our YouTube channel rather. You can watch and rewatch as many times as you would like. Because as I said earlier on, there are lots of things that were said here about, I mean, this little time we spent here will not be enough for you to internalize. For me as a person, these are things I would want to go over again and over and over and over again until it becomes like something that becomes like a part of me. So you may also want to do that. So kindly subscribe to our YouTube channel and also follow us on all our social media platforms. We're on Instagram, Threads, Facebook, LinkedIn. So please kindly help us to. You can also follow us for more health-related content, rather than for the poll, where we have a total of 4 responses. I can see more attendees than the responses. It wouldn't really take so much time. Just help us to click on, just complete the webinar poll before we end. I would like to appreciate everyone who participated, especially our panelists, Dr. Adeniran, Dr. Olusonya, Miss Jenny, and every other person, and all the participants here. Some people have left, but for those of you who waited to the end of the webinar, I would like to say thank you very much to every one of you. And this webinar continues quarterly. So in the next quarter, we'll definitely be handling something different. I have learned a lot from this particular webinar. Health financing is very dear to me, and health policy, health financing is very, 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 very dear to me, because even if you know all your stuff in the world, and then you cannot translate it to helping patients, what's the goal? And I see a whole lot of times when I was in teaching hospital where you just move all the stuff, and at the end of the day, your patient cannot even do a full broadcast. And then I could remember then, whenever we come to the ward, because I'm a hematologist, and they would always say, oh, hematology, your patients are always dying, because most of the times they cannot even afford, most of, in the investigations, nurses don't like to see us on the ward all the time. They just don't want us to come around. So for me, health financing is a big deal, a very, very big deal. So thank you so much once again for all our panelists and then everyone who participated in one way or the other. So thank you so much. We'll be seeing another time. Thanks, everyone. Thanks for coming. Please do not forget to complete your poll. Thanks, everyone.
Thank you for having me. Bye.
Thanks. Bye.
Thank you, Sinlab. Bye.